Good afternoon. My name's Jim Bueller. I direct the Public Health Surveillance and Informatics Program Office in the Office of Surveillance, Epidemiology, and Laboratory Services, and I'd like to welcome you to our quarterly seminar. It's my pleasure this afternoon to introduce Dr. John Brownstein. One of the more remarkable developments in the field of public health surveillance in the last 10 years has been the increasing interest and engagement of academic investigators who are interested in public health surveillance and informatics and who are doing a great deal, I think, to provide an engine for innovation and collaboration with those of us who work in the field of public health practice. And the work of John and his other colleagues at Harvard is an excellent example of this. We're proud that the Harvard Group has been one of our grantees in the Centers of Excellence for Public Health Informatics program that we've supported. John Brownstein is an associate professor at the Harvard Medical School and directs the computational epidemiology group at the Children's Hospital Informatics program in Boston. He obtained his PhD in epidemiology at Yale University, and he's collaborated with CDC and other federal agencies over the years. Many of you may know him through his work in HealthMap. He has a number of distinguished accomplishments, but the one I'd really like to draw attention to is the fact that last fall he was the recipient of, from President Obama, of the Presidential Early Career Award for Scientists and Engineers, the highest honor for that the United States government bestows on scientists and engineers in the early stages of their research career. We're delighted, John, that you're with us today, and we look forward to hearing your presentation on digital disease detection.
Great. Well, thanks a lot, Jim. I want to really appreciate your invitation here, and to Kathy and to Taha for having me here today to speak to you about our field, a new sort of nascent field, although not so nascent, of digital disease detection. I'm going to give you a fairly broad overview of the activities that we've been involved in over the last 5 years, sort of a whirlwind tour of different types of applications that we've been utilizing around the use of the web and mobile phones and social networks to actually understand population health. So a way that I like to start giving sort of a context for this area is by putting up a stock graph. This is a stock graph for Guangzhou Banshan Pharmaceutical Company. And you'll notice in 2003 that stock started to rise dramatically. And that was a result of a financial report that came out that basically from this company saying that the sales of an antiviral herbal product that was known to have antiviral properties was starting to rise dramatically. And the sales were going through the roof in Guangdong province as a result of mysterious illness that was taking place among school children at the time. And reports came out in both in Chinese press late in 2002 and into early 2003, thinking potentially this was an unknown new form of influenza. Only months later was this, of course, recognized to have been SARS. Now, of course, it's very easy to go back retrospectively and see all the different data sources that we might have been able to tap into and say, well, we should have, raised the alarms. But it does give an indication that there is data in sort of unique places around the world that if we tapped into them, we could actually get a perspective on population health that you can't get through sort of traditional means. And so that's sort of the context for why we're thinking about how we tap into various forms of data that are often siloed and not used for the purposes of public health, bring them together to really understand what's happening at the individual level. So, of course, SARS is one of a number of events that have occurred over the last 15 to 20 years, events that all represent very unique situations around emerging infectious disease. So SARS is one example, but there are many other events that if we could have done a better job to detect them, we could have potentially had a better impact. And so actually our group has spent a lot of time painstakingly trying to understand each event of international significance that has occurred over the last 15 years, trying to tease apart various data points, where the event took place, when was the onset of the first case, the laboratory confirmation. All these different dates we painstakingly put together over a 2-year period. Fortunately, no database. It would have been nice if the WHO had a database of all these different events, which they don't. But so we had to piece together emails and news reports and all sorts of other types of information to create this baseline data set. Interestingly, one sort of interesting point from that data set which is an N of 400 events was that the majority of events, emergence of diseases in populations, There's a lot of discussion on landscape change and transportation networks, all sorts of different factors for the emergence of disease. The majority of events actually that emerge in populations are really as a result of breakdown of public health measures. So potentially less sexy than sort of the climate change aspects, but which are of course important as well. But really there is a sort of a basic issue around sanitation, vaccination, vector control. These are the things that are leading to the majority of events of international significance. But from our perspective, we created this baseline data set for one reason, which was to understand how long it takes for when an outbreak starts to when it's discovered in a population, and then how long does it even take before it's even seen or heard by the public. And what we found strikingly, and potentially, and we can talk about whether this is good or not, it takes around 3 weeks before anybody knows that something is actually happening in a population, over a month before it's actually lab confirmed, and almost a couple months before even WHO releases a report about that event. So in reality, that's probably a much longer time than anybody would want from a point of view of early detection and doing something about an event that emerges and has the opportunity to emerge in the matter of hours or days. And what was also striking about this result was that, in fact, there's actually a change that's happening in the population. So in public health surveillance, where maybe in the mid-90s, it would take months before something was actually discovered, to actually on the order of a few weeks now in the last few years. So we're seeing a significant change and improvement over time in public health surveillance, but of course, 3 weeks is still not good enough from the point of view of early detection. So, and this is probably preaching to the choir in terms of the flow of information and the issues that as information goes from the public, people get sick, seen by clinical practice. Information, of course, flows through these various channels, eventually ending up, for instance, here or WHO. That process that we've studied it, can take, and you all know very well that process can take on the order of weeks or months. And so our goal or our thinking has been, what about the data sources that don't require that flow, that hierarchy of flow of information that's one direction, that doesn't ever get back to the individuals, to clinical practice? What are the data streams that are available to anybody? And that's sort of the basis for digital disease detection, because we're tapping into data that doesn't have, is not proprietary, it doesn't have sort of place, it's not controlled by anybody, it's available to all stakeholders. And especially from the perspective where stakeholders are not necessarily defined a priori, it wouldn't have been, so for instance with SARS, it wouldn't have been clear that ED physicians in Toronto should have had access to the same information public health officials in China. And so I think that's the basic idea, is making information transparent and available to as many people as possible. So when we think about digital disease detection, lots of different data sources that we might think about in the context of an emerging event. There's all this data that's flowing up, that's bubbling up from individuals, whether it's mail or Facebook or text messaging. All this data is coming up as an event emerges, and some data sources are more noisy, some are more timely, and so each data source has a unique advantage in terms of if its utility in an event, but we know that each has an opportunity to be useful. It's just a matter of how that information is organized and brought together into one place. And I can't stand here and say that we're inventing this new field, because in fact there are two groups that have really initiated this concept over the last decade, or actually almost 20 years now. ProMed, which I'm sure many people here in this room are subscribers to, which is really the first infectious disease social network, even though that's just based on a mailing list, and GFIN, the Global Public Health Intelligence Network, which is really the first web crawler that came up with the idea of using news aggregators as a way to understand what was happening in populations with no public health infrastructure. Over time, this idea has taken place, has taken hold in the public health community, and there's a number of groups that are coming up, and this is only a subset of academic groups, governments, now industry is getting into the mix, trying to understand how to utilize these data from the purpose of public health. And we've been involved in taking our unique perspective on this topic with a program called HealthMap, which we started about 5 years ago, with the idea of making as much information available to the general public, to clinical practice, to public health, through crawling and organizing content from across the web. We also have been trying to figure out new ways, and I'll tell you why in a little bit, why we've been trying to engage consumers and really think through why an individual would want to come to a site to see what the diseases that are flowing in their neighborhood, as much as they would go to, say, the Weather Channel site. And so we're trying to be weather.com for disease in a way. And also try to produce original content. This is our online news site called The Disease Daily, where in fact we try to bring context, or try to provide a little bit better information about disease events that are occurring, to bring it more to the consumer level. But basically, the idea for HealthMap is to produce an automated system that's freely available to all stakeholders that organizes both official and unofficial data into one context, that organizes disease, by location, through many different types of languages, and builds a resource for essentially everybody. So I'll just give you a sort of a basic explanation for how HealthMap works. So the idea is we're trying to pull in as many different data feeds, sources that we can find. So essentially we collect about 93 total aggregators, which represents over 50,000 websites. So we're constantly hitting these sites every hour, looking for particular keywords about disease in 10 different languages. That's, I won't name them offhand, but Chinese and Arabic and Portuguese, French, Spanish, and essentially with specific language context, looking for particular keywords about disease. And so we collect about 2,000 new disease alerts every day from across the world. And this, if you put this into perspective, and this is an issue from an evaluation standpoint, if we only have a gold standard about 400 events over 15 years from the WHO, 2,000 events per day represents a challenge so it's interesting that there's much more data, but it's also a challenge from an evaluation standpoint. How do we start to understand the value of this data, given that there is no good global baseline for all these different events that we're collecting from? And we've taken different steps to achieve that. And then once we've collected all that information, we've precisely placed, so we have over 10,000 locations around the world that we automatically geocode this data into. So essentially what we do is once we collect in an article that had some form of disease-related content, we're constantly looking, we're using natural language processing to look for specific keywords. So if it's a disease mention, a location mention, the number of cases, we're constantly putting in that information into one, so taking free text and making it into a structured database. And so the idea is we have all this unstructured free text about disease events. Now all of a sudden we've created a database of all events from around the world from all these different sources that we're collecting from, and across location, disease, species, and counts of cases and deaths. Of course, you can imagine there's a lot of noise in this data. We're collecting all sorts of garbage, frankly, and so we have to figure out ways to minimize the information overload to people so they're not dealing with that kind of noise. And so we have a Bayesian filtering mechanism that essentially is like a 5-way spam filter. So essentially, information that is breaking news or maybe a warning of an event about to take place because of some sort of environmental situation, we categorize and extract and remove out information that might not be of relevance to the user, and then we cut that information out. And once that information is the sort of the good types pieces of information are brought into the system, we do text matching. So of course you're going to see an event replicate over and over again in the system. We use a similarity score to essentially organize that content so we have all the different pieces and perspectives about an event on a given topic. We then rate events. We have algorithms that essentially rate diseases in specific locations. We have curators. We have about 10 people on our staff that are looking through this data every day that make ratings. And then on top of that, we essentially have users come in and rate. So if anybody uses Netflix, the same idea. You're rating your movie on Netflix. Here you're rating your outbreak on HealthMap. And so within the hour, that information is mapped and made available. So our goal, and it's a goal that we're attempting, is as soon as anybody's saying anything about a disease event on the web, that should be within HealthMap within the hour. And that's sort of the mission that we've sort of put forth for ourselves. So HealthMap over the years has built sort of a user base, and of course we work closely with the CDC and provide content to just a lot of people in this room actually, provide content to WHO, to many state, local organizations, but we also provide information to NGOs, to various organizations in the field, but also to clinicians, to travelers. So we're trying to fulfill a role that, for multiple stakeholders. So it's challenging to create a tool that's of use to all these different types of individuals. And actually, HealthMap also has a few different museum exhibits as well, one being at the Smithsonian. So one good example of the utility of HealthMap, or at least a prospective use case and how it became utilized, was around the emergence of H1N1. Now the first pieces of information that came out about H1N1 weren't out of official reporting out of the Mexican government, but actually out of local news media. So at the beginning of April, we were getting local news and chatter about a mysterious event that was taking place in Veracruz, Mexico, which was sort of a mysterious unknown respiratory condition. Now, it's very easy retrospectively to say we detected it earlier, weeks before, but once again, there's this challenge of how do we extract this particular event from all the other types of respiratory conditions that were being reported on the web. And so that's really the challenge that still lies ahead of us, which is to think about what an article, when a journalist talks about this particular event, what is different from all the other sort of localized acute events that don't sort of make their way around the world. But from what was utilized during H1N1 was to provide a global perspective on the emergence of H1N1. And so very rapidly we can crawl the web from news media and official sources and ministries of health websites to produce a picture of what was taking place in real time over hours and days that H1N1 was emerging, in a way that we could create this global trajectory of the emergence of H1N1 from country to country based on these various pieces of information, and produce a sort of a picture, a global picture in real time that wasn't sort of available through other types of channels. So that was an opportunity around H1N1. Of course, the data that we're collecting also put into focus that there's really incredible disparities in terms of certain countries' abilities to actually confirm cases of H1N1. So there were certain countries that had ability to confirm and had the laboratory capacity to confirm within days, and then there was countries that had situations where they couldn't confirm for months whether they had H1N1. And so that, of course, puts into focus sort of the massive disparities that exist. And I know it's hard to see, but I can share with anybody the paper afterwards. But basically the idea is that there's incredible issues in terms of global capacity to understand the emergence of disease around the world. At the local level, we could also utilize the information we were crawling to actually look at school closures in real time. So we were crawling, and because everybody was very acutely aware of what was happening, we could detect school closures via local media and local news streams in a way that we could quickly see which schools were getting hit very early on with H1N1, and then do essentially an analysis of those sort of case schools compared to control schools in those same locations to see what was differentiating them and what particular aspects of those students made them more vulnerable. And of course, what we found was that there were certain socioeconomic factors, travel history, potentially issues of just having schools where parents might have had more political influence, more influence to shut down the schools, but possibly there was some sort of travel history or healthcare issue that was associated with certain schools getting hit earlier on in the epidemic. So that was a quick overview of just HealthMap, but we recognized very quickly that the idea of just crawling the web and looking for reports is only going to get us so far. There's really an issue of validating, ground truthing the information we're collecting, and really connecting to the people that actually want to utilize the information. And so we work with two organizations, the International Society for Infectious Disease, which runs the ProMed system, and the International Society for Travel Medicine, GeoSentinel, of course also a part of CDC as well, and working with those organizations to work with those networks of individuals that are on the ground and can help us with ground truthing and actually utilize the information. These are two sort of partner sites for ProMed and GeoSentinel, but we're doing more than just trying to map the information that they're capturing in those systems. And if for people who don't know GeoSentinel, I think probably most people in the room do, but it's a network of travel clinics that are seeing travelers returning home and actually getting diagnoses for potentially pathogens that they picked up on their travels. And actually, this is a screenshot of the new ProMed site that actually exists within the HealthMap system at this point. But our concept is that, well, what if we can feed information to those people, to the people on the ground that need to make certain decisions, clinical decisions, public health decisions, to those communities, but then also get information back from those organizations for instance, discovery of new content, to get contextualization and ground truthing and validation of the data that we're collecting. And so we think there's an incredible value of organizing content, making it available to people that could utilize that information, and then get validation back to us. But when we think about sort of the value of those networks, they're also very limited because there's the end sample size of those types of networks still is in the tens of thousands. And when we want to think about improving surveillance and getting engagement across the world, those communities are still only going to get us so far. And that's really why we're trying to push sort of the concept of participatory epidemiology, getting the public back into public health and directly engaged in the process of inputting information, and not just the public being sort of getting siphoned from information from them, but also pushing information back to the public and making them part of the process rather than just being an information feed. And the first way we did that was with an iPhone app called Outbreaks Near Me, which was an idea of giving people information, direct information on their phones about the disease events that were taking place around them. And so it was using the GPS location of their phone to essentially send a message to our server and say, what are all the disease events within the vicinity of this person? And also, and actually we just released a new version of that app a couple weeks ago, the idea also was to not only allow people to see the disease events and also get alerts when they say step off a plane and want to know what's happening, but also report back into the system. So they can report in a human outbreak or a human event, a disease, or an animal event. So of course we know with the example with West Nile virus, people reporting on dead birds. Here is a facilitating easy way for people to report on those types of events. And what we're pleasantly surprised about was that very early on, once we launched the app, we got enough traction to get people to be utilizing the application and submitting in. So within the first week, we had over 100,000 downloads that enabled us to actually start taking this beyond just the prototype concept. And so with that success, we built the Android version. So we also have an Android in the Android market. We also recognize that we should probably do something with this, which is SMS-based and phone voicemail-based, so people can actually send us a text message or leave a voicemail, which people do, surprisingly. And then people can tweet to us if they prefer to use their Twitter account. They can, of course, utilize the web. So, if they're just on the website itself, they can send us a piece of information. Oops, going the wrong way now. And then probably our least successful tool, which is the Facebook app called Outbreaks Near Me. We just can't get the traction in that particular community. They're all on Farmville. So anyways, we need to figure out a way to get them more engaged into this tool. And we have ways we're thinking through how to do that, but it's just not quite there yet. Another way is actually just to scare them through the film Contagion, and we've actually been able to get ourselves sort of working with Participant Media, which developed the film, to work with them on the content and the social campaign that surrounded that film, and actually to get HealthMap featured within the film and get people actually into our system that way as well. So that was a nice sort of partnership for us that brought in a lot of traction. And as much as you might be thinking, who would actually want to do this? What are the incentives? And I'll talk about incentives in a little bit. In fact, there are a lot of people that are willing to do this. It's just a snapshot of a couple months worth of data of people coming to our system and reporting on disease events. So these are individuals with no real incentive other than just be part of the public health fabric or just be a dot on the map. And we're getting data from all parts of the world. Of course, you can see there's some bias in places where we get more data than other places. And we get good use cases. So for instance, there was a chikungunya outbreak in India recently, and the first reports didn't come from governments, they didn't come from news media, but actually the first report that we found was actually a physician that was reporting us via Outbreaks Near Me, telling us that there was an event taking place that was most likely to be chikungunya, although the Ministry of Health wasn't being forthcoming with that information. Weeks later, we then found this out to be chikungunya, but this represents, and of course and I'm sure a lot of people are thinking about the noise and the issues of this kind of data, but there is an opportunity for this data to be somewhat helpful and guide public health efforts. We also get a lot of individuals telling us they have the flu. This was during H1N1, a lot of people sick and saying they had flu-like symptoms. They may have flu-like symptoms, it's possible. We of course can't diagnose them, but we also have people that are getting into the system just sending us garbage. But we can subset this stuff too. So that's easier than some of the other the actual true noise that we get into the system. But from a perspective of comparing this and Lynn's in the room, and everybody likes to do the comparison to CDC ILI data, but in some ways the data that was really only a small sample size could provide us a correlation to, this was the second wave of H1N1 in a way that was somewhat correlated. Now, of course, with much more participation and activity, we could do a lot better than that, but it did point to us that a fairly cheap system that only costs in the thousands of dollars to develop and basically has very little maintenance costs can actually be something that's extraordinarily useful. At least there's a possibility for this type of data to be useful. And we think we can go beyond that, not just getting people to engage. And so we think through different ways of getting people more engaged in the app through recognition. Do people want badges like they get on these other sites where it's more like a gaming quality? You become a digital disease detective, or what are the ways in which people care that they would get involved in the system? But we do think there's an opportunity to get people more geographically, so with the geographic data that we're capturing, get people really engaged in the system. So for instance, we get a lot of undiagnosed events into HealthMap on a daily basis. This is an example of one in Chiang Mai over the summer where it was a mysterious illness. We weren't sure what was taking place. But what we do know is that we have all these users that are within some vicinity of that particular location. So in the new version of Outbreaks Near Me, we actually have an ability to query out, based on geographic vicinity, the users of our app, and actually ask them, have you heard, we've just got this report, have you heard anything about this event? And, of course, there's a lot of things that need to be considered when we push out a survey like this. But imagine an ability just to press one button and actually have a ground truth survey with zero cost, zero efforts in the field, just to get some better context for what's happening. And so there's opportunities to really improve our ability to get information with very little cost. So I just want to talk for the second part of the talk, really, to talk about applications of digital disease detection. How are we utilizing this data from a public health perspective? And I'm going to give a few different examples for how these data are becoming helpful, or we think are at least towards getting helpful. There is a system called Google Flu Trends, which I'm sure many people in the audience have heard about, know about, have problems with potentially. But it was a tool that was out there, and it's made available, and it's freely available to see what people are querying on the web, potentially that has correlation to epidemics. And now, of course, we know that search terms and people's attitudes on the web change, and with H1N1 there were issues around this tool. But as a first sort of glance about what's taking place, this produces sort of this frontline effort to at least see what's taking place in addition to all the other data streams. But with flu, there are a lot of other really successful data streams. With dengue, for instance, there is not a lot of extra data that's out there. And so we worked with Google over the last couple of years to think about, well, how do we take that technology for Google Flu Trends and think through how we do the same thing for dengue. And in selecting a disease, it's tricky because you have to have a place that has enough internet connectivity, but also a disease event that has enough morbidity where people would actually be searching, because only some subset of those people that are sick are going to search on the web. And so dengue actually represents this really nice sort of sweet spot. Malaria does as well, actually. And where we could start to model dengue epidemics and see whether we could develop this global surveillance system. Now, the trick actually was to get gold standard data, and this is sort of the trick to all these different things I'm going to talk about, is how do you actually model dengue where there's really no free dengue data or surveillance systems that are out there. So we painstakingly, over a year and a half, went through all the gray literature, dug deep into PDF files across different ministries of health, begged for data, which didn't work. But we did get a lot of data that we could find off the web. Actually used the free software where you scrape off graphs and turn it back into data. Data Thief, if you ever use that, I highly recommend that software package. And actually that's how I got my PhD done, actually, is with Data Thief. And it totally fine, totally up and up. But anyways, the idea was we were able to get first an initial set of 5 countries where we get epidemics and actually start to then train the model. So we took test epidemics and then were able to then actually test that model based on the training that we had done. And we got actually quite good fit. And based on that fit and the ability to essentially develop models for each of these countries, we could actually produce a tool, Google Dengue Trends, which is now freely available. We published on this as well. And in fact, since we published on the first 5 countries, we've been able to add another 5. So that we have 10 countries total now. And for certain countries, we actually are able to develop risk at the provincial level. So that's also very exciting. We, of course, want to expand this to other countries, but it's a question of how we find the data out there. Another way that we've been working on dengue is actually working with CDC Yellow Book data. Of course, as we know, that data is produced at a regular interval, but there's a lot of spacing between the updates that occur. So our goal has been to think through, well, how does our data sort of help provide an additional view of what's taking place? As we know, for instance, with dengue, the boundaries of disease risk are changing constantly, and we know that there's new locations for Aedes aegypti that are being sustained. So what can we do to provide a sort of living, breathing risk map that allows us to see the trajectory, the moving border of disease risk? And so actually working with the dengue group, and now this is linked off the CDC dengue page, we can actually provide a combination of CDC Yellow Book data, which is much more validated, but in addition to this epidemic intelligence on top of that data provides sort of a nice sort of combination. And we're, of course, doing that with yellow fever and other diseases as well. And in fact, now with the launch of the 2011 Yellow Book, we can begin to start to validate our data. So now we know there are new regions in 2011 that weren't in 2008. Does our data help sort of, were we predicting those regions we're going to take, whether those regions were actually going to be in 2011? And we do that with pretty nice sensitivity for Latin America, less so for Asia. But the specificity issue is still there because we are still predicting areas that have risks that are not in the CDC Yellow Book. And so that's a question still of, how do we ground truth those locations? Are they areas that have sustained transmission? Are they areas that just have importation of cases that then are not with no sustained transmission cycle? So that's still an existing challenge for us. Another way that we've been able to use our information is in disaster settings. So during of course, after the earthquake, we all know about the events that took place around cholera. The map that we developed, a specialized map, was not only able to sort of bring together all the disease events that we knew that were taking place around cholera, but also merge that and match that up with crowdsourced information on clean water sources, on clinics, data that wasn't necessarily available in one spot and wasn't really available publicly in an interactive way. So we were working with Ushahidi, which maybe some people in the room know about, Crisis Mappers community, to create sort of a community around putting in data that wasn't available previously. And we're also able to develop tools that actually helped clinicians in the field to provide them with a window into what was taking place. So based on the data we were collecting, we were able to provide clinicians that were working in Port-au-Prince with some information on whether particular types of diseases were on the rise or not. And so anyways, I'm not going to get into the details of that, but there were opportunities to get information from the field as well. But we also recognize that there was opportunity to even just analyze the data coming out of social media streams. Now, this might seem completely wacky to some people that Twitter might be a useful source, but we started looking at actually people utilizing Twitter within Haiti. To a subset of the data of people mentioning cholera was actually coming out of Haiti, which was surprising that people were on these social media sites. Now, if we start to monitor the volume of tweets that mention cholera over time, that volume actually starts to mimic very closely the epidemic that's coming out from hospitalization data and case information, at least in the first two epidemics. Once we hit the waves, in the third wave of cholera, the attention span of people sort of waned and people were less interested. So you see the social media issue where people are less attuned to actually reporting these things. And actually that's a problem across the board for the stuff that I'm talking to you about today, because it requires people to have some attention, some interest in what's happening. But what we were able to do is actually see whether, and using the exact same methods that some of the recent papers have tried to estimate are not from the hospitalization data, see, well, can we use those methods on Twitter data? And in fact, our estimates for R0 were perfectly, at least for the second phase, exactly within the range of what was being reported by official sources. And even for the first wave, it provided enough information that, utilizing these social media streams at least can give this first glance estimate. What order of magnitude R0 are we dealing with at this time? And you can do that in real time. Of course, every situation is different, and of course, understanding various issues like serial intervals are of course problematic. But from a first effort to try and look at these things, Twitter actually could be a highly useful data stream. So people look at disasters in thinking about focused areas that one might want to monitor disease events. In similar way, mass gatherings represent this sort of focused area to look at disease events as well. This is a picture of the Hajj, and I've been working closely with collaborator Cameron Kahn at Biodiaspora to understand how the movement of people into to locations of mass gatherings and then movement out of those places to understand transportation networks and the probability that a disease moves into a mass gathering and the probability that it moves out. And so we've been working on various types of mass gatherings. This is a slide from Cameron, where basically you can actually make predictions as to what you think is what would be the predicted flow of people into a particular mass gathering, because it's highly predictable. And then you can also predict where those people are going to be moving out of. So you have this ability to essentially make some predictions of where diseases might spread if an event does take place at the mass gathering. And so, for instance, for the Hajj, we always create a yearly map that provides users with information on where people are coming into the Hajj and where they might be going home. We do this also for the Olympics, for FIFA World Cup. So we've done this over and over again for various mass gatherings. So it's the same principle each time. So of course we recognize that mass gatherings and population movement and migration is highly important. And based on that concept, I've actually been working very closely with Marty Cetron and DGMQ on a project called Biomosaic. And it's a project that I think Marty's probably spoken about before, but it's this idea of going even further. How do we start to contextualize risk information based on the various types of information that contribute to risk? The Biomosaic project, which is sort of an effort to try to analyze and visualize very complex data streams, sort of combine around three basic topics: demography, so understanding the various aspects of the populations that are at risk; health information, so producing, what are the surveillance data sources that we have access to; and then migration, working with the biodiaspora team to think through how the movements of populations might influence risk. And that's all, of course, centered around the foreign-born population that is at the intersection of those three things. And so I don't have time to get into the details. This could be a full talk. It can easily be a full talk on its own, but the idea is we're trying to build a prototype that essentially has all this information that someone can do analyses that combine the risk information, say that you get from HealthMap or other data sources, with all the different available demography variables and migration variables. And this can be done, of course, before a crisis or, of course, during a crisis as well. And just to give you a sense, of course, we can identify vulnerable populations easily from the census and various variables. We can start to put together maps that allow sort of individuals in public health, both at CDC but also at state and local, to actually understand the makeups of their population and understand underlying risk in the community. As I mentioned, migration data also coming from very detailed information that we have on people's the transportation network, both around the world and within the U.S., and of course U.S. border statistics, and then health data that comes from HealthMap, but also a number of other CDC data sets as well. And our group has been developing a mobile version of this interface. I'll let other people talk about the web version that's very powerful and extraordinarily visual, but the idea is also to create a tool that allows people in the field to produce queries and understand the makeups of various populations while people are doing, for instance, surveys. And the mobile application that should be released very soon allows people to quickly see, what is the makeup of the population, what is the risk in this particular area based on the disease information. So it's trying to bring together the context in addition to the disease surveillance that we're involved in. This is just because I'm Canadian, I wanted to show that we have map of essentially foreign-born population from Canada. In addition, those blue circles represent the border crossings for February 2010. And so you can start to mash up all this type of information from and then start to integrate health risk information in there as well. Okay, so that's just one project. I could go on much longer for it, but a few other things that I wanted to mention. I'm not sure if people can see what they're looking at there, but one of the major issues that, of course, we face is in both from a conservation standpoint, but also from a disease risk standpoint, is the wildlife trade. So taking on a completely different topic now, but I'm going to talk about how sort of the availability of our technologies are actually useful for instance, from monitoring trade that potentially has an ultimate risk of affecting from disease risk through sort of zoonotic transmission. And we know many examples of how the wildlife trade has actually led to disease events in populations and the spread of various pathogens. And so what we've been working closely with the Wildlife Conservation Society and actually a project out of USAID called Predict, which also includes the Global Viral Forecasting Initiative and the EcoHealth Alliance, to try to create a comprehensive tool that monitors events as they emerge in populations with a focus on zoonotic disease. And one of the facets of monitoring zoonotic disease is the wildlife trade. And so we developed a tool called the Wildlife Trade Map that essentially, instead of monitoring health events, is actually monitoring interceptions and reports of illegally traded animals. So essentially we have, instead of disease categories, we're actually looking at species categories and the reports of an illegally traded animal in a particular location. Now, it's a controversial subject because, of course, when you're putting out a map like that, people might think, well, now, thanks HealthMap, you've just put a menu of the various animals that I can go to this particular location and buy up. And so we have to be very careful on how we present this information. For instance, we have a map, a layer of all the markets around the world, and basically we know every species, or most of the species that you can get from that. We don't put that up on the map. But actually at this point, with the iPhone app, Outbreaks Near Me, people can actually take a photo of an illegally traded animal, submit it to us, and in fact, that's a back channel way of getting access to that kind of detail as well. And of course, I had to put up a word cloud because no talk goes without a word cloud these days. So just to give you a sense of the different types of species that we're collecting from our system. Okay, another 180-degree turn. So another way that we can start to reorient our system is around vaccine confidence. Of course, people here are no strangers to the issues of vaccine uptake and rumors that emerge as a result of a variety of reasons why people start to distrust pharmaceutical companies, public health around taking vaccine. And so we have been thinking through how do we begin to create vaccine confidence indices to try to understand where we might see uptake issues around the world. Of course, as an example of polio, that the lack of uptake of polio vaccine has actually translated to the spread in many other countries. And this is just one of many examples of, we've seen, of course, measles being more locally relevant has been a concern over time as well. So we've actually been working with the London School of Hygiene and Tropical Medicine around a global system for vaccine confidence, where we're mining Google, we're mining social media, mining all these sites to actually understand what is the potential issue of what is the rumor that's circulating, and what is people's attitudes and beliefs towards vaccine around the world. And this project is still, it's a Gates-funded project that's still in its infancy, but already is produced, so we actually have a live streaming system, once again, as an example. So I think there's a very similar theme here, but a map that is actually then monitoring all the rumors and confidence issues that are taking place around the world, potentially with the ultimate, issue of an eventual outbreak that takes place in these populations as well. And you may think that some of these, or probably not, that these rumors are emerging in other parts of the world, but UK, for instance, represents like a hotbed of rumors for all sorts of vaccines, and we've been able to monitor all sorts of different issues that have taken place in developing countries. Okay, so the last thing, the sort of last part of the talk that I really want to get into is this issue of incentives, and why does anybody even care about getting into our system in the first place? Why do people want to report? Potentially there's even security issues, risks that people might have to reporting. Talking to people that don't want to even get on Facebook because of issues of losing potential issues of privacy. So one area that we've thought about is what if we just start paying people to report to us? And so there's a system called Mechanical Turk that's produced by Amazon. I don't know how many people in the room are familiar with it, but the idea is it's microfinancing, micropayments to do small tasks. And so the majority of people that have used Mechanical Turk are for the purposes of identifying what are the objects in this image, and it's for a machine learning project. But we thought, well, what can we use Mechanical Turk for a public health purpose? The idea of Mechanical Turk is you have access to an on-demand workforce of hundreds of thousands of people that will just do small tasks that take like a minute to do, and it's just additional income for them. And so we worked on a project, and this is around the emergence of a major malaria epidemic taking place in Mumbai, where we asked people just for a few cents to tell us how they were feeling, tell us whether they got a diagnosis for malaria, tell us even whether they knew if there was Vivax or falciparum. Surprisingly, people actually get that information, and the proportion of people within the people that actually told us what they had, it matched up beautifully well with what the public health was reporting. And so we could get highly detailed geographic information on people that had malaria diagnoses at a high geographic resolution. We could get demographic information, all sorts of details. Once again, just by pressing a button in Boston, all of a sudden we have all this data that we can utilize to see the trajectory of an epidemic. In fact, we've had a lot of trouble to validate this project because the gold standard data has just never been made available. So we're still sort of waiting to see how good the data was. But in the meantime, we're seeing there's huge opportunity to start collecting this kind of information. Another way that we're trying to do that is just hopefully to plead to people that they should just do it because it's their civic duty, which has worked to varying degrees. So we launched a project called Flu Near You, which we launched with the American Public Health Association and the Skoll Global Threats Fund. The idea of querying people on a weekly basis in a standardized form about flu symptoms. And this is different than Outbreaks Near Me, in which we're just letting people just go wild and just tell us anything they wanted. Here we're only allowing for very specific structured information to flow into the system. And so we launched this tool that was meant to be a comprehensive tool. So it's not just what people are reporting, but we mash up CDC, various CDC data layers, Google flu trends. We brought in Google Vaccine Finder. So in fact, when you open the browser, auto-detects your location, produces all the vaccination clinics in your area, so you can go get the vaccine. So it's intended to be sort of a comprehensive tool for people to see about risk and see what they can do about it. And the idea is we put out a form, and actually I know there's a bunch of users of flu near you in the audience, which is wonderful, which is the idea of quickly report in your symptoms that you're experiencing. If you're experiencing any symptoms, give us an indication of when you got ill. You also can tell us whether you got the vaccine or not. Those questions disappear once you've told us you got the vaccine. So the idea is to try to be as annoying as possible until you eventually get the flu shot, and then you don't have to answer that question anymore. But so the idea is it takes a few seconds each week to fill out, maybe more in some weeks because we've had some server issues, but overall, attempting to be as low-hanging fruit as possible. Now, the way that we have tried to incentivize this project is working with American Public Health Association around a challenge where individuals, so members of the APHA can go out and recruit people onto the system. Now, the people in the system aren't paid, but the people in the APHA community and organizations within APHA that have an incentive to try to get the public engaged in public health can actually win some real money. So we've had some people that have done a pretty good job on this, but I have to say that there's people that are still not thinking outside the box. APHA's perspective, yeah, well, it's a public health community, they don't have a lot of resources. I completely disagree with that perspective. I think there's a lot of innovation within the community, and just people haven't taken the time to think through ways of getting large amounts of people into the system. But so far we have over 5,000, actually 6,000 people in the system, which is not bad for 4 months of being live, people reporting in weekly. So it's not bad. We're hoping for 100,000, maybe 1 million, but for a starting point, it's not bad. It also hasn't helped that we've had a very mild flu season. I think we'd be much better off. Well, we wouldn't be better off, but if we had a better flu season, there's no easy way to say that. But anyways, just it would have been nice from a data perspective. And actually one question that we get a lot is in terms of the age distribution of people utilizing the system. Oh, this is only young people. But in fact, if we just look right now at the snapshot of age, the 55 to 65 age group is actually one of our major users of the system. So it's not actually, geared towards, the fully young age groups. And so that's very exciting to see that in there. Although this double peakingness is kind of interesting. So we think that taking this perspective on getting people online, seeing their data compared to everybody else, being part of a social network is sort of an interesting phenomenon. And it's been working not just by us, but there's other groups that are thinking through how to do this in effective ways. And of course, our attention started turning to BRFSS. Well, what if we started thinking through other ways of taking survey data and bringing this into the context of the public and getting people engaged? So we actually have a prototype now that's not live, but it's the same concept. People can register to be part of iBRFSS. The name is just a prototype name. It doesn't have to be that. But the idea is you quickly register, you get an email back saying, sign up, just to confirm your email address, and then you start going through the system in the same way that you would do on the phone survey. So going through the exact same questions, and this is live now, I can show people the link after, but that they can go through the questions and the various different questions about hypertension, cholesterol. We have to think through all the various issues of collecting this kind of data. Of course, BRFSS, the way it's collected is very different. It's not opportunistic like something like this would be, so it represents very different types of statistical analyses to handle this data. But there's an opportunity to really think through how to collect data from massive, huge amounts of population with basically very little cost. I mean, to run a system like that, as I said, is not millions of dollars to run. It's very cheap. So it's just another concept to think about as we're thinking about the value of these different tools. Of course, you can think about doing this not based on surveys. So a lot of people are pushing for the idea, well, why are we doing surveys at all, since we can just harness what people are already doing on the web and not ask people to do anything. So you'll see the Facebook like button. Actually, the like button is actually potentially an extraordinarily valuable tool for public health. We're thinking through ways in which people are liking on various pages like Weight Watchers or this is Boston Marathon. What does that tell you if you really like, if you like Weight Watchers, what does that say that you really like the Boston Marathon? Does that reflect your health status at all? And so we're thinking, well, how do we create sort of a Facebook Healthy Cities project? Like how do we, using the data without actually having done a single thing, see how healthy a city is or metro areas or state is based on the amount of liking of various subjects. And so we're working on a project now to think through, are the healthy indicators based on what people do on social networks related to what, for instance, BRFSS tells us about the health in particular states and metro areas. It's highly in its first version, and we're still working on what the right indices need to be, and there's all sorts of different healthy cities indices that are out there. But there's an opportunity just to start harnessing that data as opposed to even going out and asking people in the first place. So it's really a combination of data mining, and so it's actually not sort of one or the other. It's how do we merge data mining of data existing information plus engage people directly to be part of it. And I think people will be more likely to be part of it if they already see some level of data out there. Okay, so I'll just wrap up there, and hopefully there's a few questions. I mean, the idea for us is really we see there's extraordinary value in the fusion and organization of all this extraordinary content that's out there on the web. And we think that these systems can play a role, and that we hope that they are, and there's still a lot of work to do to evaluate these systems. But we think, because of these early efforts, we think that there's a role for them, not as a replacement for traditional systems, and I have to always be clear that, we're not trying to say that these systems can replace the traditional efforts of EPI, but they can be important adjuncts to what's already happening. So I'll leave it there. Thank my team at HealthMap and at Children's Hospital and the various funders, and open up to questions. Thank you very much. Any questions?
Hi, John. Dave Swerdlow from NCRD. So if I understood the report that you described from La Gloria, Mexico, you heard about an outbreak of respiratory diseases with 2 deaths on April 1st, and the initial isolates were here around April 15th. So you could have potentially identified outbreaks 15 days earlier than we did with our mechanisms. And so have you thought about what it would take to be able to track down all those reports that you get? And, given the background noise of reports and events, and what kind of resources or what kind of efforts would it take to be able to have actually identified the pandemic earlier? I mean, how many reports of respiratory illness do you get a day? How many reports of any kind of event do you get a day? And how many would you have to have evaluated before it would have been a useful tool to identify something prospectively, not retrospectively?
Right. It's a great question, because we have such varying levels of reporting from events that are highly localized. They'll never be of real national significance or international significance. We get, dozens of respiratory disease reports every day. We have lots in the database, more than sort of an individual would have time to sort of, and especially if we lowered our threshold for what we think is an important event. We're working on ways with machine learning tools to take the reports that have been sort of the leading indicators of major events. So we have a baseline of 400 events, although they take place over a long period of time, to see, what was the discussion taking place before those events, and develop machine learning tools to say, well, what is in that particular text that's slightly different from events that talk about things that don't end up spreading anywhere. It's a real methodological challenge, one, so we're attempting it on the methodology, but there's also, an individual challenge. So we have curators in our system that are tuned to trying to make the data as clean as possible, but they're not necessarily, and they have the IHR protocol to really think through, is this event sort of an event of international significance, and then we send out an email to over 20,000 people. But I think there's also, we also need a little bit of help from our public health partners on this, because it's sort of this black box. We're sending information constantly to various partners, but it's very hard to get any feedback about what ended up being a real event, what was useful, what was not useful. And with that kind of better baseline, we could do a much better job of filtering down the information to pieces that would sort of rise above the noise, and then say that Gloria report was actually of significance. And so we need a little bit more help. Not that, we don't have great collaborators, but nobody has time to sort of go back and give feedback to the system on what was useful. So we have to think through ways to, because we're an academic group in Boston, we don't have that ability to chase down every event that we collect. So it's a resource issue on our end, but I think there's an opportunity from a community standpoint. And working with Ray Arthur and the GSAG group, I mean, there's ways in which people are trying to attempt to validate this information in a much more community sense. So, great.
Hey, John, thanks very much. I sit here and I wonder whether you think as fast as you talk, or whether it takes a critical mass of a team to come up with all these ideas. They're fabulous. I'm struck that you are probably pressured by many of the same forces, particular as syndromic surveillance and the utilization of these tools came to light via some pressures on Homeland Security, terrorism preparedness, and those kinds of things, on this detection situational awareness dichotomy. David's question sort of stimulated that same sort of, well, yeah, that's detection. How are you going to really detect through these systems versus, the real benefit on the, contextualizing events as we know that they're going on. So I was wondering whether you could give some perspective on, obviously you've got some pressure to be using this for the detection side, but how you're seeing, that's paying some bills but allowing you to do other things. Is this likely to be more long-term valuable in the contextualizing versus the detection side?
Yeah, I mean, that's a great question, and we've faced that issue with syndromic surveillance, where it turned out that early detection wasn't really, the value of the data, and it turned out to be situational awareness, and we've seen sort of the value of syndromic surveillance for ILI surveillance, for instance. And we've definitely taken the situational awareness approach mostly. I mean, the idea was how can we provide as much information about an event as possible, but you're right, we are pulled into the detection side of things, because that's really where the sort of, what everybody really wants at the end of the day is, can we push that needle by a few days, by a few weeks? I think we have to be very careful with the promises we make with the system. I think it's still worth, sort of research investigation, a line of investigation, seeing whether this data is available from that perspective. But it's a difficult. So we've been able to skirt away from that subject by really making this more of a situation, like combine all the data, making it a mashup for everybody to see what's happening. And that's really been sort of our mission. But yeah, I mean, we definitely don't want to fall into the over-promising that syndromic surveillance may, and the ultimate sort of failures that came from it. So it's a tight sort of a fine line that we walk there. Thanks, Dan.
Hi, I'm Louisa Chapman. I'm currently working with the Situational Awareness Group on detail here. Very interesting talk, and you were going pretty fast.
Yeah, I try to put in too much.
Yeah, and I'm a rural southerner, so it's hard for me to think that fast. But a couple of thoughts that kept coming up in my mind as I watched what you were doing were representativeness and validity of data. And, when you say, well, we could identify this flu outbreak 2 weeks earlier than your surveillance did, that sounds great, provided it's going to hold up, which we won't know for 2 weeks until our surveillance confirms it. And when you talked about people could go on and make a little money by reporting, I was wondering, well, how do you keep 16-year-olds from going on and making up something to report every time they want enough money to get a Coke out of the machine? So what safeguard, or what processes and information sources do you have, or do you have any, that allow you to assess representativeness of what you're hearing about and the validity of what's being reported beyond or prior to being able to compare it to established public health surveillance systems, that kind of thing? Yeah, I mean, it's great points, and I sort of couch when I show the ILI stuff. It's it's easy to just say, hey, we detected things 2 weeks earlier. It's still, these are nascent systems that are sort of in their initial phases of trying to be evaluated for what they're useful for. Of course, we're not making laboratory confirmation, although that is actually on the plan, which I haven't talked about. But trying to think through the validity of that data over time and whether it really, first of all, represents the population. So with Flu Near You, we're gonna spend a lot of time thinking about what parts of the population we've captured, which parts, how representative our sampling is. So it's nice to see that we're getting specific age groups. What about various SES factors and other things that make this sort of a more robust system? So that's still an ongoing research challenge for sure. The issue of validity of information and false reporting. I mean, for instance, for the malaria project, you got paid whether you said you had malaria or not. So there is no real financial incentive to giving a false report. Now, it doesn't mean that people don't want to just play around and game the system, and we expect that level of noise to exist, and we have to account for it and model for it, and we expect that it's going to be there at all times. Interestingly enough, when we actually we spent a lot of time curating the data and looking at this information. And interestingly, we don't see a lot of people trying to game and play around with the system. And this is not just in our system, but there's a number of other crowdsourcing projects that are out there in the humanitarian space where people are actually really trying to, the amount of noise that happens is very limited, and people are actually, as much as it's constantly this push where you're always going to get people that are going to try and game the system, it doesn't happen as often as people expect it will. Now, I'm not saying it can't, and we don't want to try to account for it, but there's not really a huge amount of incentive for people to do it, at least in the systems that we're building. Yeah. Oh, all right. Yeah. Go ahead.
We've hit the end of the hour, so I'm sure, John, if you've got some extra time, perhaps happy to stick around. But for the sake of wrapping things up for the IPTV audience, let me punctuate right now and take a moment to thank John for a really fabulous, very fascinating presentation. It's given us a lot to think about, and you've got at least one more download over the course of the hour. So thanks very much. Stick around and keep asking.
Yeah.